Okay. This is a principle of knee joint. Knee joint is very complex. This is a combination of morphology and soft tissue balance and alignment. So soft tissue decides the morphology, and the morphology decides the alignment. And the total alignment is influenced by the soft tissue, and the result is a very complex combination of the kinematics produced. The combination of these three items. As a result, the patient morphology, soft tissue, and alignment and kinematics is quite different among the patients. There's not decided only one. So it is a very difficult thing in terms of the knee joint. Unlike the hip is a very, very simple joint because the hip is stabilized by the bone and very, very conformed joint. The kinematics is very simple, only one axis, only the cup and the center of the femoral head, that's all. So we should start about the alignment. In the last talk, I talked about the alignment, especially in the coronal alignment. So there are the two types of the femoral axes. One is the mechanical axis, that is connection, the line between the femoral head center and the knee center. And the second is the anatomical femoral axis, that is the axis of a femoral shaft. There is some divergence, difference of the angle, approximately 6 degrees. On the other hand, regarding the tibial side, tibial axis, the mechanical and anatomical is virtually same, but in the patient with severe alignment, a proximal beta tibial para patient, that is very frequent in Asian countries. The two lines, the anatomical axis and the mechanical axis, are slightly different. But it is allowed only the 1 degrees. It's very small. So we can consider the tibial axis, the mechanical one and the anatomical one are virtually same. And to express the alignment or coronal alignment, we always use the Miklik's line. That is the line between the femoral head center and the ankle center, and the location of the knee that pass the Miklik's line on the joint line. We express this line, the intersection, as the percentage. The 50% is the center. The 0% is the medial side and 100% is the lateral side. So if the line pass the 25%, it means the loading line, Miklik's line pass in the just center of the medial condyle at the knee joint. And FTA, we can calculate the FTA on the short film because only anatomical axis can be seen in the short X-ray film. But if we get the long X-ray or leg X-ray or CT scan, we can calculate HKAA. That is the most frequently used to express the coronal alignment of the knee joint. So HKAA is considered to be 0 in the normal patient. And that is the joint line, the green line, the joint line. Joint line is approximately 3 degrees medially sloped. And more recently, the joint line orientation angle the inclination of the joint line against the floor is focused on. This is a review of the previous vitals. So we should check and focus the other more alignment in the coronal plane. One is the lateral distal femoral angle, that is the angle between the femoral mechanical axis and femoral joint line, that is the line between the medial lowest point of the medial condyle and the lowest point of the lateral condyle. But to calculate the LDFA, we need the long X-ray or CT scan. It is quite difficult to check, calculate on the short film like this. Another one is the medial proximal tibia angle, MPTA. Those are approximately 3 degrees in betas in the LDFA, the valgus, betas in MPTA and valgus in LDFA. And HKAA is the angle between the femoral mechanical axis and the tibial mechanical axis, that is considered to be 0 in the normal patient. And this is the line between the femoral joint line and the tibial joint line. We call it the joint line convergence angle. That is the inclination is the both joint line. In the OA joint, lateral JLOA open laterally and lateral OA open medially. And again, in the healthy knee, JLCA, sorry, this is a misspell. JLCA is virtually 0 parallel. And LDFA and MPTA can express the native HKAA of these individual patients. So maybe I told about these angles. Then I moved to the alignment more. So we call the ideal alignment as a mechanical alignment. This is very important to perform the TKA because the normally bone cut is made against perpendicular against the mechanical alignment, mechanical axis. So on the femur side, we cut the distal femur, the perpendicular to the femoral mechanical axis. On the tibia side, the cut perpendicular to the tibia axis. Regarding to the tibia side, it is relatively easy to identify the tibia axis intraoperatively because we can directly touch the femoral, the tibial crest intraoperatively. So we can feel the crest of the tibia and we can identify the tibial long axis. But femur side is quite difficult to detect the location of the femoral head. So only we can recognize directly the precisely is the femoral canal. Femoral canal is virtually same as the femoral anatomical axis, but more precisely, the medial canal axis is a little bit different between the true anatomical axis because the line, the femoral canal line is the line between the entry point of the femur distal end of the femur, that is insertion of the iron rod. So if the iron rod shift to the medially, this angle increase, and if we make the entry point slightly laterally, the divergence between the mechanical and anatomical femoral axis is the decrease. So it is quite sensitive in the entry point of the IM rod and tip of the rod. So anyway, so we consider the direction of the IM rod intraoperatively as an anatomical axis of femoral axis. So we calculate the angle, make the angle between the anatomical axis and decide the mechanical femoral axis, 6 or 7 degrees, the valgus direction, and make the perpendicular line and cut the distal femur. As I said before, this line, joint line, the slant medially approximately 3 degrees. So generally saying, the distal cut thickness is thicker in the medial side and thinner in the lateral side. On the other hand, on the tibial side, the lateral thickness is thicker, on the medial side thicker. But intraoperatively, you must feel the thickness of medial side and the lateral side is virtually same. And in some cases, the lateral side is thicker than the medial side. This is due to the bone wear of the medial side on the OA knee. If we cut the bone in the patient, normal patient, we always cut medial side thicker. But on the OA patient, the partly the cartilage wear occur, and then bone can be wear. So the medial thickness is getting thinner and getting thinner in the advance of the OA. On the other hand, the tibial side, the lateral side is still normal, even in the late stage OA. But the medial sides, similar to the femur side, the partly the cartilage wear can occur, and then bone wear can occur. So the difference of the thickness on the lateral side and the medial side getting bigger. So this is the difference of the femur side and the tibial side. Okay. So anyway, so we always on the mechanical alignment TKA, we cut the tibia and the femur on the perpendicular to the femur on the tibia axis. Oh, but we should design the rotation axis that is the bone cutting line, posterior condyle cutting line. So just like to the distal femur, so we cut a parallel to the tibial axis. So bone cut thickness of the posterior condyle is thicker in the medial side than the lateral side. It is quite natural because the joint line incline medially in both extension and flexion. So if we cut the parallel to the tibial cutting line, that is the thicker in the lateral side and the thinner side in the tibial side. So in the flexion, the cutting line is thinner in the medial side, lateral side, and thicker in the medial side in the flexion. So it is very important point. So in the mechanical alignment bone cutting, on the tibial side, lateral side is thicker, and the medial side is thinner, and the posterior condyle, lateral side is thinner, and the medial side is thicker. In the extension, distal femur, in the normal knee, lateral side is thin and the medial side is thick. but as a result of the bone wear and the cartilage wear in the medial side, the lateral side thickness is the same thickness in most patients. This is very interesting. So the medial side, joint side is slant medially approximately 3 degrees. So the bone cutting line, this one should be make the 3 degrees in angle against the joint line. So joint line is virtually same as the PCA, posterior condylar axis. So we can know the precise the bone cutting alignment in the flexion. So making the angle between the joint line that is similar to the PCA. So we just cut the bone, refer to the PCA and make the angle normally 3 degrees, in sometimes 5 degrees. So because again, we quite difficult to recognize what is the parallel axis of this one. This one must be the flexion extension axis. So knee joint will rotate around this line. So this line is considered to be the SEA, surgical epicondylar axis. That is the line between the lateral epicondyle and the medial epicondyle. But it is slightly posterior from the tip of the medial epicondyle of the femur. So it is quite famous. The SCA is the rotation axis on the femur. And in the same time, this line is perpendicular to the femur and the tibia axis and perpendicular parallel to the tibial cutting axis. Okay, this is a very basic. Okay, so again, this is the green line is transepicondylar axis, SEA or EPA. This is considered to be the rotation center of the knee joint, flexion extension axis. And this is parallel to the tibial cutting line. Tibial cutting line is perpendicular to the tibial axis again. And this line, green line, EPA or SEA, makes the 3 degrees of angle against the PCA or joint line. Okay, and in clinically, we can know this line using the white sign line. White sign line is between the lowest point of the trochlea and the highest point of the intercondylar notch. White sign reported that this line is virtually perpendicular to the SEA or EPA. But it is quite variable. Some patients is virtually perpendicular. Some patient is rotated externally. So again, we should decide the rotation angle, refer to the epicondylar axis or PCA and makes a 3 degrees or 5 degrees, and white side line. So because unlike the tibia side, to decide the femoral rotation axis is quite difficult, so we need to know some body landmarks and referring them, and we made a precise decision to make to decide the tibial rotation axis. Okay, so if you can use the CT scan you can recognize easily the transepicondylar axis. But you must know, there are two types of transepicondylar axis. There is a different bony landmark. So one is the line between the lateral epicondyle to the medial epicondyle. We call it the clinical transepicondylar axis. But clinically, we frequently use the surgical transepicondylar axis, that is the line between the lateral epicondyle and medial sulcus, that is the small dip just posterior to the eminence of the medial femoral epicondyle. So, and difference between the posterior condylar axis and clinical transepicondylar axis we call is the chondrial twist angle, and angle between the PCA and the surgical transepicondylar axis we call it the posterior condylar angle. But we frequently use this angle as chondrial twist angle. Or maybe this is quite similar, so we don't need to distinguish the two lines. But roughly, we should consider to the as the transepicondylar axis between the sulcus to the lateral epicondyle, and the angle between the PCA and this epicondylar axis we consider it to be the condylar twist angle, approximately 3 degrees. So more precisely, use preoperative CT scan and calculate this twist angle, and intraoperatively we should adjust the rotation angle to cut the posterior condylar parallel to the transepicondylar axis. But it's quite variable because some patient has this angle is virtually 0, and some patient more than 10 degrees. But it is a worry about to the cut the posterior condyle, the making the angle from the PCA more than 10 degrees. It's quite risky. So in normal, the surgeon adjust the angle, this angle between the 3 degree to the 5 degrees. So in my operation, I design this angle as 3 degrees, all cases. It should be the best. Okay. This is the sizer. So explanation of the rotation angle. So intraoperatively, the most reliable the bony landmark to decide rotation is the posterior condylar line PCA, that we can know by the push the paddles of the sizer on the posterior condyle, and we can recognize we can know the PCA, then decide the rotation angle. The sizer makes the rotation on 3 degrees or 5 degrees. In some sizer, we can adjust freely 0 degree, 1 degrees, 3 degrees, so we can adjust it one. Anyway, so this sizer decides the rotation angle, this one. In the same time, the size is between the distance from the posterior condyle to the anterior cortex. Then make the hole here and to the take out the sizer and put on the cutting block. So this is using this technique, we can decide the rotation alignment of the femur precisely. Anyway, so this is a talk about the gap. So, the purpose of to decide the proper rotation angle is the make the proper gap. The proper gap is considered to be the parallel and equal gap. Rectangular. There are the two rectangles that is made by the two cutting plate of the from the femur and tibia. That should be make the rectangular the parallel gap, and this rectangle is the same size, same distance in both extension and flexion. So parallel and equal gap should be made. So if you cut the bone like this, the ligament balance should be perfect. So as I said before, the knee in the joint, the ligament balance is very important. That is the essential, because basically knee should to make the stability in the two long bones, the femur and distal. So we need a very good stability by the soft tissue, by ligament, muscle, and the capsule. In the same time, the knee should move very wide range, full extension, the full flexion. So to make this good function of the good stability in the good mobility, ligament balance is essential. So to regenerate, to restore this good balance, we should cut the bone the parallel in the extension and flexion. So this technique, the basically, I'm sorry. Okay, this is the explanation is the how to evaluate the gap. It is quite difficult, but normally we can use the spacer like this. This spacer thickness is same as the tibial side component thickness plus femur side component thickness in the both flexion and extension. So this is after the bone cut, we insert this spacer and feel, make sure the gap is not too tight and not too loose. Too tight can cause some stiffness of knee or the wear of polyethylene, and loose gap can cause the instability and excessive wear of the polyethylene. So, but proper gap, to evaluate the proper gap is very, very difficult. So I recommend to evaluate the gap, proper gap, as a very smoothing, but after the insertion of this the spacer, and you should apply the varus and valgus stress. And if the joint open more than 1 millimeter, it implies that it is too loose. So on the other hand, that is a tensor. Tensor is the one device, a device to make the distractions traction, distracted stress. But it is also the very variable tool. So because we can evaluate the both gap and angle between the bone cutting planes. But it is it is available in the very, very limited situation. So normally you should use the spacer, but I think spacer is enough. But you should evaluate precisely rightly to if it is loose or not. But you need to precise evaluation, you need experience. Okay, okay, this is the end of my talk. Last talk I tried to upload my talk to the YouTube, but I couldn't. So this time I recorded to my talk, and I will upload this video on the YouTube. So if it is succeed, you can see this talk on the YouTube. And the next week, I will continue my talk. So please come and join. And if you have any question or some comments, please send me my email. I will answer your question on your comment. Okay, see you. Bye-bye. Have a good night.
Bye-bye, Professor.
Bye-bye. Oh, totally.
Bye-bye.
Oh, bye-bye. Bye-bye. Hi.
Yeah.
I'm sorry, this is the end of my Zoom. Sorry.
Yeah.
This is a free version.
Yeah, it's okay. It's okay.
Okay, see you next week.
Okay.
Enjoy.
Yeah.
All right, bye-bye. Bye-bye, everyone.
Bye-bye.
Bye-bye.